Hello and welcome to my channel. In this channel, we explain various nursing concepts in a simple form for a better and easy understanding. These videos could be used by both LPN and RN students as well as nurses who are trying to refresh their basic concepts. My name is Nasmosh. In this video, we're going to talk about GI disorders, more specifically esophageal disorders. So first, gastroesophageal reflux disease, GERD for short. So GERD is a gastric disorder where gastric content and enzyme backflow into the esophagus. We normally have some backflow of stomach content, but with GERD, there is over backflow of this, which could be due to stenotitis, HESI hernia, or excessive inter-abdominal or intergastric pressure, sometimes motility problems. With GERD, this could cause some pain, mucosal injury, esophagitis, which is inflammation of the esophagus, as well as Barrett epithelium. So with Barrett epithelium, the cells that line the esophagus become mutated from the continuous exposure of the stomach acid, and they are more likely to become cancerous. So some of the risk factors include obesity, older age. With older age, we normally have a delayed gastric emptying or sometimes the weakness of the LES tone. So with older people, we know that everything is coming down, right? It could be also sleep apnea, people who have an NG tube. We have smoking, alcohol use, being pregnant, ascites, Herschelinia, being in a supine position for a long time, and people who consume a high fatty diet, which could be even fried and some spicy food, also caffeine and citrus fruit. Some signs and symptoms include dyspepsia, which is indigestion. They could have a throat irritation, possibility a bitter taste, because remember when you have that belch, when the backup of it doesn't taste good, it's bitter. We could have the burning and pain sensation in the esophagus, and when they lay down, this pain will get worse because remember, you're flat, right? And when you sit up, it kind of holds gravity, it holds it down, so it kind of gets better. And they always have some chronic cough. Some treatment for this, we could have medications, and some of the medication include the proton pump inhibitors, the PPIs. They end with zole, like omeprazole. We could have antacids, and with antacids, we always educate the patient that we normally consume this or we take the antacids when our secretions are highest, which are normally an hour to 3 hours after eating and at bedtime. So after you eat the food, you normally tell you it takes 3 hours to digest, right? So that's when we are increasing. The signals have been sent to the GI tract to increase the secretion of the enzymes that are used to break down the food. We can also give them histamine receptors antagonists, which end with dine, and they reduce the secretion of acids in the patient's stomach. We could give them also prokinetics, and prokinetics like metoclopramide, they increase the motility of the esophagus as well as the stomach. They could have surgery as well, which is one of the surgeries is fundoplication, and fundoplication is always performed after all the other treatments fail, right? We've given them medication, we've changed their lifestyle, so this is like an end result, and this is where the fundus of the stomach is wrapped around and behind the esophagus, all right? We need to teach the patient to avoid fatty, fried, or spicy food. They should eat smaller meals. The patient should remain upright after eating the meals. Remember, when they lie supine, there's that reflux. Sit up. Gravity will help you push it down. The patient should avoid tight-fitting clothes because remember, when you're putting pressure, because some causes of this is that pressure of having pressure pushed to the stomach and causes that back up, right? So avoid tight-fitting clothing, and they should have their head elevated at night because that's when we have the increased secretion of enzyme in the GI tract. So for an angle of maybe 6 to 8 inches, avoid them from being completely supine. Peptic ulcer disease. So peptic ulcer disease is where there is an erosion of the mucosa in the esophagus, stomach, or duodenum. Some key risk factors for peptic ulcer disease are chronic use of NSAIDs, stress, and H. pylori infection. And signs and symptoms include heartburn, bloating, possibility of bloody emesis or stool, pain, and the pain will be different depending on the location of the ulcer. We'll have some vomiting. So with gastric ulcer, the pain will be worse for the patient 30 to 60 minutes after the meal, and the pain will be worse when eating. With duodenal ulcer, the pain will be worse between 2 to 3 hours after the meal, and it will actually be worse at night versus during the day. It will feel better when the patient is eating or taking antacids. So diagnosis of this is normally done with a GED. Esophageal duodenoscopy. Treatments include multiple use of ABTs, which are antibiotics, to reduce the risk of the H. pylori infection. We'll also give them H2 receptor antagonist and proton pump inhibitors as well, and antacids. And remember, antacids, we tell the patients to take it between 1 to 3 hours after meal consumption when there's an increase in gastric enzyme production. We'll also give them mucosal protectants, which we give them 1 hour before the meals to protect the GI tract. We teach the patients to avoid acid producing foods like milk, caffeine, and spicy food, and they should avoid the use of NSAIDs like ibuprofen. Some complications include perforation. When you have an ulcer, it could perforate. And signs and symptoms of perforation include severe epigastric pain, rigid board-like abdomen, hypertension, and tachycardia. Esophageal variants. So with this disorder, we normally have swollen, fragile blood vessels in the esophagus that can easily hemorrhage and cause excessive breathing, and this could be life-threatening. Some of the risk factors of this include portal hypertension, and this could be due to a liver dysfunction, for example, cirrhosis or hepatitis. These are the diseases that end up with hypertension or portal hypertension. With portal hypertension, there is an increased blood pressure in the veins that go from the intestines to the liver. Some signs and symptoms of this are elevated liver enzymes, because this is a disorder that has a liver dysfunction. So our AST and ALT levels will be increased, and since there is a risk of hemorrhaging, we'll also check out for signs and symptoms for hemorrhaging, which are decreased hemoglobin and hematocrit. We'll also have tachycardia and hypertension. Sometimes we'll have elevated ammonium levels. Treatments. With treatment, we're going to do medications like vasoconstrictors and non-selective beta blockers, and sometimes surgery is used as an intervention. Example of a surgery that could be done will be a variceal band ligation or a transjugular shunt placement. Irritable bowel syndrome, IBS for short. So with IBS, this is an intestinal disorder that causes the patient abdominal pain, diarrhea or constipation, and some gas. With this, we teach the patients to avoid foods that can cause this gas, right? So like dairy, eggs, wheat products, alcohol, caffeine. They should also increase fiber intake as well as fluid intake, and they need to keep a diary of the foods that they are taking to note which foods trigger these symptoms. So once they know, if I eat maybe, let's say, broccoli, I will have more signs of this. So they note it down and they avoid broccoli. Medication for IBS. So IBS is treated with either medications that prevent IBS with diarrhea and IBS with constipation. So there are two various types of IBS. So IBS with diarrhea, we administer allosterone, right? And with the one with constipation, we do lupestrone. With lupestrone, right? So some people remember with constipation, you use the lube, right? Lubricate. With diarrhea, you use aloes. With aloe, like aloe vera. Since you're diarrheaing, you need to calm it down, and aloe vera does a good calming sensation. Intestinal obstruction. So with intestinal obstruction, there are various types of this. It could be either mechanical, and with mechanical, we're normally caused by adhesions from surgery, sometimes tumor, diverticulitis, as well as fecal obstruction or fecal impaction. Non-mechanical could be due to paralytic ileus, and people normally have paralytic ileus when everything stops working, like with narcotic use or after anesthesia. Some causes of this paralytic ileus could be neurological or vascular disorders, electrolyte imbalance, and inflammation. So signs and symptoms could be there's a signs and symptoms of intestinal obstruction, abdominal distension, obviously. We're gonna have an severe constipation, abdominal pain, and with this, we're gonna have high pitch sounds, hyperactive sounds above the obstruction, right? They're doing their job, but below the obstruction, there's nothing, hypoactive bowel sounds, because they're not receiving anything, so they are sleeping, they're not working. So when dealing with a small bowel obstruction, because there's either a small bowel obstruction or a large bowel obstruction, so with a small bowel obstruction, the patient might have projectile vomiting, and with this vomit, it could smell like fecal odor, right? Like feces. They will have severe fluid and electrolyte imbalance. We are vomiting, right? We are getting out this electrolyte. If we don't replace it, then we have an imbalance. They may exhibit signs and symptoms of metabolic alkalosis with large bowel obstruction. The patient may have diarrhea or ribbon-like stool. So with ribbon-like means that this stool wants to come out, but we have a blockage over here, right? Remember, your GI system is a tube. So think about you have a stone that is not, is a big stone. So you're trying to push this liquid through this tube that has a stone. The liquid would come through it. Whatever you're pushing will try to come to the spaces where it can fit itself. It will be ribbon-like, right? Because it's trying to push itself through. And this ribbon-like stool will be working their way around the impaction of the large intestines. With large intestines, right, our stool is formed. That's why we'll have this ribbon-like. And with the small, remember, small intestines, we haven't started bulking it. So it will be just fluid, right? So with this nursing care, we always place the patient on NPO restrictions immediately. Always. We place an NG tube, and remember, when we place this NG tube, GI processes, remember, check the video if you haven't. We place this NG tube, we always check for placement. With this, we'll send them for an X-ray to check for placement, or we aspirate the GI content and check for the acidity. Very important. If this NG tube is not placed in the right place and you go to flush this patient's NG tube, guess what we're doing? We are putting that fluid in the patient's lung. All right, so we check for placement, and this NG tube is placed there to what? Decompress the intestines, right? To relieve the compression. Now, your GI system is having an effect of a pressure cooker, and you will need to let out that steam to come out. So we decompress it. We administer IV fluids and electrolyte for the electrolyte imbalance as ordered. And when a patient has surgery with this to correct the obstruction, if we need so, they will have a colon resection, which could involve a placement of a colostomy, and they could also have lysis or adhesion that may be contributing to the obstruction to remove whatever it is. So remember, if we have in the small bowel, we'll have an ileostomy. If this obstruction is in the large intestines, we'll have a colostomy, and that will lead to the stomach placement. Key thing to remember with NG tube placement, they could ask you a question. You have a patient who's an NG tube due to obstruction, and the patient is complaining of discomfort. So we'll check first, is the NG tube in place, right? We check from the patient going out to the equipment. So make sure the NG tube is in place so that it's performing the job that it's placed for. If the NG tube is in place, is it patent, right? Is there any blockage in the NG tube that is causing it not to perform its job? We go back. Okay, our NG tube is working. What next? Our suction machine. Is our suction machine working? Is it on, right? So if our suction machine is not working, we make sure the suction machine is working. And with checking if there's any blockage, we don't introduce gas into this patient. Remember, this patient is gassy. We normally flush and Remember, if you're flashing anything in the NG tube, this NG tube has to be where? In the patient's stomach, because we don't want this fluid going into the patient's lungs, and we can end up giving them a nosocomial infection, pneumonia, due to aspiration pneumonia. Thank you for watching. Please like, share, and subscribe to my channel. See you on the next one. Bye.